And we just said tardive dyskinesia. I want you to write down on tardive dyskinesia on the top is EPS. EPS and tardive dyskinesia is the same. And what is the meaning is here is tardive dyskinesia, smacking lips, and also the tongue movement. And write down the word is involuntary movement. They're moving involuntary movement. They may use the word extrapyramidal, tardive dyskinesia. They're moving involuntary movement, smacking lips, and moving the tongue. What did we say? Side effect of antipsychotic medication. Next is verapamil and amidron. Those two are important words. Verapamil and amidron are, these are cardiac medication, but they can be increased digoxin level, increased serum digoxin level, possible cause ditch toxicity. Verapamil and amidron, these drugs can cause digoxin toxicity. Next line, I want everyone should know digoxin toxicity. What is a normal ditch level? Write down 0.5 to 2.0. That's a normal level. And what is the sign of digoxin toxicity? Everyone, I want you to underline the word in the first line, anorexia. And write down on the top of anorexia, nausea and vomiting. And anorexia means loss of appetite. So remember, your patients start losing weight. They're not having any appetite, they're not eating. So anorexia, I want you to memorize like that. Anorexia, nausea and vomiting. Second line, visual disturbance. So later on, they have problem in vision. Halos around the eyes, they can say. Yellow halos, that's a vision. Bradycardia, the pulse rate is going down. And in infant and small children, first symptom of overdose cardiac, underline the word dysarrhythmia or arrhythmia, the last line, in the children. And also in the infant, side effect of digoxin toxicity is vomiting. So write down the word vomiting, and bradycardia is in the children. Let me tell you in the adult, anorexia, visual, bradycardia, and I want you to add one more thing is lowering the potassium level. So whenever you give digoxin, you should check the potassium level. It affects it. So what are the sign and symptom? This is the way you memorize 0.5 to 2.0. Anorexia, visual, bradycardia, and also low potassium. What pulse do you check when you're giving digoxin? Apical pulse. When patient is going home, then you check radial pulse. Are we okay? Next is restlessness. Underline the word fat embolism. And what is fat embolism comes from? Now I'm going to talk a little bit about the fracture. Now, and then I'm going to connect you with fat embolism. So when your patient has fracture, I want you guys write down in your notes, lead to fat embolism. And what does fat embolism leads to? Pulmonary embolism. So here it says, pulmonary embolism when patient has is restlessness followed by temperature. Later on they have high temperature, but everyone remember when you have pulmonary embolism, your patient has restlessness. Are we clear? So what is the early sign of pulmonary embolism? Restlessness. Also, I want you to write down there headache and tachycardia. So early sign in your question of pulmonary embolism is restlessness, tachycardia, and headache. How do you get pulmonary embolism from fat embolism? Why do you get it? When your patient has fracture. Everyone is okay. How do you prevent fat embolism? How do you prevent fat embolism in your question? Is how do you prevent fat embolism? What do you do when your patient has a fracture? Anybody?
Mobilization.
Do not ambulate. So what is the word is called? Immobilization. Immobilized your patient. So how do you prevent fat embolism? Immobilized. Are we clear? So how do you get pulmonary embolism from your patient with fat embolism? I want you guys all, you write down what are the other complications of your fractures are. Is number 2 is osteomyelitis. Osteomyelitis. And number 3 is compartment syndrome. So whenever your patient has a fracture, your first thing is fat embolism and pulmonary. What is osteomyelitis? Infection of the bone. So what do you prevent? Infection of the bone. And when they treat the bone, you got to monitor compartment syndrome. And what do you monitor here? Neurovascular assessment. And 5 P's we just did in the last is there are 5 P's and you are monitoring neurovascular assessment. Everyone is okay? What are the 3 complications of your patient when they fell? Is number 1 is fat embolism, number 2 osteomyelitis, and number 3 is compartment syndrome. How do you get pulmonary embolism? Let's write it down, that too. So it will come, but you get it in a different ways. So any question come in a fracture, you got to prevent them from fat embolism, you got to prevent them from osteomyelitis and compartment syndrome. Now these are the complications. Now let's go pulmonary embolism. What are the reasons for your patient to go pulmonary embolism goes in respiratory? What are the reasons for your patient to have pulmonary embolism? Is number 1, we said, is fat embolism. Are we clear? Fat embolism leading into pulmonary embolism. Number 2, air embolism. How do you get air embolism, which is leading here? If air goes in your IV and TPN, and also write down the word hemodialysis. Your patient is going in hemodialysis, the air can go in and it can lead to pulmonary embolism. Number 3 is DVT. How do you get it? DVT. What is deep venous thrombosis? Comes from your patient is laying in a bed. Are we clear? So if they ask you, how do you prevent your patient from pulmonary embolism? And they say fat embolism, what do you do? Immobilize your patient. Are we clear? They fell. First thing, you immobilize them. What do you do if your patient is getting air embolism? Turn the patient, everyone write down, to the left side and lower the head of the bed, more like a Trendelenburg position. And you make sure in your IV and TPN, no air goes in. As soon as your IV finish, you change your IVs. But if your patient is going in air embolism, they ask you, what do you do? This is your answer. How do you get air embolism? And that goes in your dialysis patient. Your patient is in dialysis. What is one of the complications is air embolism. Are we clear? What is the third one is DVT. How do you know your patient has DVT? Write down the word positive Homan sign. What is positive Homan sign? Write down pain on dorsiflexion. Pain in what? Dorsiflexion. So everyone should know. If we memorize one line, but we do not know how to think about it, our patient, then you can't work. So what do you do for your patient when they have pulmonary embolism? Maybe question with dialysis, hemodialysis, air embolism. Patient with circulation, when they get DVT, lead to what? Pulmonary embolism. Once you have DVT, what do you do for your patient? Is already deep venous thrombosis. What do you do? Are you going to ambulate? No. Now the clot is here, elevate. Turning is good. Also remember, anti-embolic stocking is good. And when you have DVT and there's a swelling and pain, you can go for warm compress. Are we clear? So DVT question goes in cardio. Air embolism goes in your renal, maybe in dialysis question. Fat embolism goes where? In your fracture question. See how your systems are connecting. Your patient is one. So how do you prevent pulmonary embolism? By three important things are, if you have a fracture, don't let your patient move. If you're giving IVs, make sure you prevent air, TPN, dialysis, but if they have is air embolism, immediately turn your patient on the left side and lower the head of the bed. For DVT, positive Homan sign of DVT, everyone should know. And how do you prevent DVT? Before your DVT comes, ambulation is good. But once you have DVT, then you will do what? Your patient should lay in bed. Which are the high risk for patient to clot? DVT. What is DVT? Deep venous thrombosis. I want everyone to remember. Your questions are not going to be what is DVT. Which patient are you going to prevent DVT? Write down the one hip surgery. Hip surgery patient is risk for DVT. Abdominal surgery patient risk for DVT. If you're taking is oral contraceptive, risk for your DVT. If you're not ambulating after surgery, abdominal and hip surgery. Everyone is okay. Your clotting time, bleeding and clotting time, delayed, and that can also cause a problem in clotting time. That can also lead to DVT. So we covered only one line, restlessness. What is the sign and symptom of pulmonary embolism? So underline the word fat embolism. And now I want you guys write down about, so everyone is okay, how do you get pulmonary embolism? And how do you get the three things are there? Now I want you to write down pulmonary embolism, sign R. For early sign is restless, that's fine, because they're not getting oxygen. For Nclex, everyone remember, early sign of pulmonary embolism is petechia over chest. What is petechia? Bleeding, they're clotting disorder. So what is the patient has? If they give you patient has fat embolism and you see patient has petechia over chest, they didn't tell you that's a pulmonary embolism. What are you monitoring your patient? Pulmonary embolism. Number two is, remember the word hypoxia. Early sign is, we said restlessness, we said tachycardia, we said headache. So early sign, your patient has hypoxia. Late sign, I would say, is you have chest pain, dyspnea, and cyanosis. See, all are your breathing problem. Number three, your patient is going into shock. And what is shock? The blood pressure is low, tachycardia, pulse is high, respiration. So what are the signs of pulmonary embolism are? Is first sign, everyone remember petechia. And they didn't tell you it's a pulmonary embolism. And they're saying, when you see petechia, what do? What are you going to do? Your patient has pulmonary embolism. As a nurse, raise the head of the bed. Always remember positioning. We are nurses. We cannot do without doctor's order. But what do you do in nursing intervention? Raise the head of the bed. In emergency, you can start oxygen. Next is start oxygen, 100% non-breather mask. Never pick up cannula, because cannula, you're not getting enough oxygen. Then they can give morphine or nitrates for chest pain. And the next thing is, you got to give heparin. Are we clear? So what are you preventing here? Clotting. So what medication are we going to give? Is heparin. How do you give heparin in emergency? You can give IV. What do you monitor for heparin? Bleeding. What is heparin is? Anticoagulant. Now, this question, wherever it comes, these are your answer. What is heparin? Anticoagulant. What do you monitor when you're giving any blood thinner? For bleeding. Are we clear? See how you covered it? You went in respiratory, you went in fracture, you went in renal, but this is your critical thinking that your patient comes in pulmonary embolism. Question can be fat embolism. They didn't tell you patient has pulmonary embolism. If you do exam cram question, there is a question. Patient is admitted with petechia over the chest with fat embolism. What would you do? They didn't say pulmonary embolism. What do? Raise the head of the bed. And what do you do as a nurse? Oxygen. So everyone must know sign and symptom of pulmonary embolism. What are the sign and symptom of pulmonary embolism is number one, remember, early sign is what? Bleeding disorder, petechia. Second sign you remember, hypoxia. What is hypoxia? Lack of oxygen. When you're not getting enough oxygen, then your patient is going in restlessness and they're going into late sign, cyanosis, dyspnea, chest pain. And what is the sign of shock? They didn't get low blood pressure, they said tachycardia, tachypnea. Are we clear? Wherever you see the word tachypnea, they're struggling to get oxygen. You've got to give them oxygen. So we covered restlessness, but we covered sign and symptom of your pulmonary embolism. We covered what is your pulmonary embolism types and how do you get pulmonary embolism. Next is neogolism. What is that word is neogolism? Is underline the word new word. And where do you see this? Write down mental health. Schizophrenic patient. Patient comes in schizophrenia and you have never heard the word and they start making a new word. So remember, this is going to be for which patient? Remember, when you have really bad mental problem is called psychosis. Any questions? Psychosis, schizophrenia patients you have, and what are they? One of the symptoms, they do neogolism. Are we clear? Making a new word. And they might say, give you a question with schizophrenia, what do you monitor in schizophrenia? Everyone remembers psychosis word, neogolism word. What is psychosis word is delusion and hallucination. Write down two more words. Delusion and see you connect some information. Somebody is making a new word you haven't heard, they have a mental problem, okay? And that goes in schizophrenia. Pancreatic enzyme. I want you to remember, where do you get pancreatic enzyme from? Pancreas. Where is your pancreas is, everyone remember, left upper quadrant. So where is the pain when your patient has pancreatitis? Left upper quadrant. What do you monitor patient with? Pancreas problem, they're not getting pancreatic enzyme. And what is pancreatic enzyme? Help in, I want you to write down the word digestion of fat. Are we clear? So what diet do you cut down for your patient when you have pancreatitis? Cut down is fat. What do you give medication for them? Is pancreatic enzyme. I want you to write down where it says pancreatic enzyme, Viocase. Viocase is also used as a medication, pancreatic enzymes in a medication. What does it help in? Digestion of fat. So when do you give the medication? Before meals. Are we clear? Or before meals or with meals and snack. So in any question, your patient has pancreatitis, what medication are you going to give them? Pancreatic enzyme. Whereas you have a problem in pancreas in the babies. Which babies do they have problem? Write down the word cystic fibrosis. So you memorize in cystic fibrosis in peds. They have a problem with pancreatic enzyme. So where do we give pancreatic enzyme? To babies with, you can give Viocase with meal, with food, with snack. And which patient are you going to encourage pancreatic enzyme? When your patient has pancreatitis and cystic fibrosis question. Next is, I'm going to move on, word delusion. Delusion is suspicious. Write down the word is false. They believe something is not true. There will be jealousy when there is delusion. They are distrust, they don't believe. So what does delusion mean? Something is not correct. So what are they believing? Something wrong. Are we clear? It's not true. Delusion means it's not true. Something they believe. My husband is cheating. My husband is in love with somebody else. Or something they see and they're delusional and they don't trust. And what do you see? And remember, in schizophrenia patient, bipolar patient, remember the word psychosis. Psychosis means something not correct, something wrong in their mind, and remember the word suspicious. UAP, underline the word chronic. We just finished earlier. You give them chronic patient. What is another word is called? I want you to write down the word. Don't give them acute word. And another word is called excavation. Any question, patient has excavation of multiple sclerosis, excavation of rheumatoid arthritis. That means they're very sick. Acute means they're very sick. Acute COPD, acute asthma, acute pneumonia. Don't assign them. Are we clear? So in assignment question, when your patient is acute, don't assign them. When your patient is chronic, that's okay. What is another word? Acute means excavation. Excavation means they're bad. What is chronic word is chronic, and write down the word remission. Remission is they're okay. Then it's okay, you give them. You have multiple sclerosis remission. Rheumatoid arthritis means they're feeling okay. Are we clear? So there are two words, chronic word, remission word. Acute word, excavation word. So remember, pay attention when you're reading your question. Whenever you read excavation, your patient is very sick. Never leave your patient. Underline that. Any question, whether it's in mental health, your patient has anxiety, your patient is afraid, you stay with your patient. Even you're taking telephone order, do not leave. Now they explained it, but always your priority is safety. So stay with your patient when you're picking up your answer. Next is for charting, inflammation. No nurse judgment, be specific. Now don't say your patient has inflammation. Underline the word stable. So if you're saying inflammation, how do you know what is inflammation? What is stable? So remember, what do you write it down? Objective. What is objective? Redness, swelling, pain, fever, right? Don't just say patient has inflammation of right leg or right foot. That will not be considered good charting. What did you observe in your patient's leg? Redness, swelling, pain, appears to be having inflammation. Patient is stable. What is stable word? Vital, what do you observe? Vital sign. Patient is alert. Patient is ambulating. Patient has no dizziness. Don't use the word patient is stable. Are we clear? So what do you remember in your documentation? Always be objective. What you observe, you chart, and what patient says, you document. Never pick up the word. Patient has pneumonia. How do you diagnose pneumonia, right? What did you feel? Write the symptom, write what you observe. So that is your documentation. Restrain. On your question with restrain, what are the restraints are? Physical and chemical. What is physical means you are restraining them physically, and you are putting side rails. You are using wrist restraint. You are using body restraint. Chemical restraints are drugs. What is restraint does? What is the meaning restraint? What is the meaning restraint? You do not allow the patient to move around. Are we clear? Restraining word is you're restricting what? Patient's movement. So what do? You give injection of Haldol and patient is sleeping. And you put the side rails, patient cannot get out. Or you tie your patient is not going to get out. Now, I want you write down one word for your Nclex before you restrain your patient. What do you do before you restrain your patient? Assess. And what do you do? Write down the word less restrictive method. Don't call the doctor and tell them, I think I need a restraint because patient is moving and climbing over the bed. So when you answer your question before you restrain, what do we do? Less restrictive method. What is your less restrictive method? Maybe lower the bed. Maybe your call light. Maybe a special mattress. Maybe a padding on the floor. Are we clear? Now, so best answer is before you restrain, what do you do? Less restrictive method. Then what do you do when you really need a restraint? You assess and doctor's order whether you're having a physical restraint or chemical. Then what do you do? Consent, right? Are you going to get the consent when you're going to having a restraint order? Do you need a consent for restraining? Yes. Do you want to put the side rails and put your patient in restraint? Do you need a doctor's order? Yes. Are you going to put the care plan? Yes. And then only one line you have. When you tie your restraint in the bed, where do you tie? Underline the word bed frame. Don't go on the side rails. That is what it says here. Where do you put your restraint and tie them on a bed frame? An easy release knot that you can open it. Are we clear? So that's it for an easy release. And you check frequently, not every 4 hours, maybe every 2 hours, more frequently. Open your restraint and let them allow. When you're removing restraint, remove one at a time. What are you checking with the restraint? What are we checking with the restraint? Physical restraint. You tie their hands, you tie their body. What are you checking? Circulation. Are we clear? What is the wrist restraint? If you have a wrist restraint, what is the problem in wrist restraint? What is the problem you tie wrist? What is the common problem with the wrist restraint? Fracture, swelling, they're fighting, and they can get fracture. What do you assess here if you have a wrist restraint? Now, sometimes they don't use circulation. The pulse, what pulse are you going to assess? Radial pulse. Are we clear? Make sure the skin is okay. So what are you assessing in restraint? Circulation. In circulation, what are you assessing? Your pulse. Are we clear? So make sure your pulse is important. Now, what do you do before you go on restraint for your Nclex? Less restrictive method. When you're getting restraint order, what do you need? You need a doctor's order. You need the consent. Are we clear? So that is the way you think you are answering your question. Next one is never ask why in your question. Gag reflex. Don't question them, but assess why you're doing that. Now, don't say, why are you doing this or why the doctor has ordered. You better look for the reason. That's what the meaning is. Gag reflex. Underline the word gag reflex. What do you meaning? Absence of gag reflex means swallowing reflex. Which patient do you monitor gag reflex? I want you to write down GI. In GI, upper GI, your patient is going, or EGD, and ERCP. You are checking GI system from the mouth. So when they're saying, which patient are you going to monitor for gag reflex? They're not going to say, what is a gag reflex? But you should know which patient are you going to monitor gag reflex. When they're going for any upper GI, and they're going to put EGD, esophagus gastroduodenostomy. ERCP is cholangiopancreatography. You're looking gallbladder and pancreas. Any patient, when you're going for this, or you are monitoring anything you're putting through the mouth. Are we clear? What do you monitor? Gag reflex. What do you hold the fluid until the gag reflex return? What is another thing you monitor? I want everyone remember the word endoscopy. Any question come endoscopy? Any question come upper EGD, ERCP? What do you monitor? Gag reflex. Where do you have endoscopy? In GI system. And you do not give fluid. Nifedipine is your calcium channel blocker. Write down the word calcium. Channel blocker. And when you are giving calcium channel blocker, is called your nifedipine and procardia. And also procardia, do not crush them. Don't crush it. You can also give them sublingual. I want you to write down, you can give sublingual for high blood pressure, PRN. Immediately, your patient whose blood pressure is high, you can give them procardia. And also you can give them procardia is for chest pain. Instead of nitroglycerin, you can give for chest pain. You can give them to improve circulation. Is in which patient you're giving in circulation? Is you have Berger disease. Berger and Raynaud disease. Raynaud disease is more in young, and Berger and is with the cold, and Berger disease is with the smoking, goes in your cardiac question. So I want you to remember, Procardia is a drug, can also be used. It's a blood pressure medication for chest pain, for circulation, and there are two problems in circulation are renal disease. What do you teach in renal disease? Do prevent them from cold. Are we clear? And also, it's a poor circulation, and they can give this. Berger disease, you always go for smoking. Renal disease is more in young people. Berger disease comes more for aged and a smoker. Are we okay? All right? Now, so we covered that. And RN is not assigned and does not have authority to tell a nurse what to do, refer to nursing supervisor. Does not have authority to tell. If you are not assigned, the meaning is you are an RN, but I'm not working in that area. I have no authority to tell other people what to do. Are we clear? So when you are only working in your area and you're responsible, then you give your teaching and all the thing and looking in patient's chart only when you're assigned. Are we clear? I'm a RN and I'm working in Kaiser and I'm working on a second floor. I have no business to go on third floor, that's OB, and I pick up the chart and I start reading. I'm not assigned there. I have no legal authority to open the chart or tell people what to do. Are we clear? So it's very important where you assign, you take authority. Next is a doctor has ordered unless contraindicated in nurse's decision. Underline the word contraindicated. Contraindicated means you question the doctor if he has ordered. Question means you ask why. Contraindicated means you cannot do. Are we clear? For example, if the doctor ordered atropine eye drops for glaucoma patient, are you going to question? Yes, because you cannot give atropine in glaucoma patient. So that's a contraindicated for glaucoma patients. Are we clear? So the question is, a lot of questions are they're asking, what is contraindicated? Doctor ordered to apply heat on appendicitis. Can you apply heat? No, it ruptures. So question the doctor. Type 1 diabetic patient, doctor did not order insulin. Are you going to question the doctor? Yes. Nowadays, don't say whatever doctor tells you, you do it. Are we clear? Whatever wrong goes in, they are looking why nurse didn't question the doctor. Are we clear? So contraindicated means you cannot do. Now the next thing is assessment. Everyone should know your assessment are percussion. Percussion is listening the sound. So what do? You put your hand and you do percussion. Palpation, you feel it. Palpation means touching, pressing on the skin. Auscultation means listening. Inspection, so accept. Now how do you do assessment, inspection, percussion, palpation, auscultation. But very important for your abdominal. If your patient has abdominal problem, how do you assess that patient? Then you're going to go inspection, auscultation, percussion, and what do you do the last thing? Palpation. Are we clear? And where do you use palpation also? Is in your integumentary system. What are you assessing? Is you're assessing by touching and feeling the skin. That is the meaning is here. You're assessing the skin. Tenderness. Tenderness means is not soft. That is you have felt in what? Palpation. So remember, palpation is used with what? By finger, by pressing, by assessing. And what are you assessing? The skin. You're checking how does the integumentary system is showing. So if you have inflammation and this is getting more, is infection, that is becoming more tenderness. Which patient do you see tenderness? In your appendicitis patient. And what do we say? They have tenderness. Peritonitis question. Peritonitis, skin assessment, tenderness. Are we clear? This came in exam. They do ask question, and we must know how do you assess. CABG. What is CABG? Coronary artery bypass. Which patient do you see CABG? Which patient you will see in heart attack, MI? And what does the patient come back when they come back? Is mechanical ventilator and chest tube. And you are monitoring patient very frequently. Are we clear? They are cardiac surgery. And they have opened up the blockage. And they have done coronary artery bypass surgery. Acromegaly. Where do we see acromegaly? I want you to write down hyperpituitarism. Which patient has acromegaly? Hyperpituitary gland. Where is your pituitary gland is? Everyone should know in the brain. Where is your pituitary gland is? In the brain. And what is your pituitary gland is doing? Is growth hormones. This is too much of growth hormone. Acromegaly, too big person. What is dwarfism? Short. And so everyone, whenever they're saying patient has hyperpituitarism, what are you assessing? Acromegaly. When your patient has hypopituitarism, what are you assessing? Dwarfism. What is acromegaly? Person is too big, and what do you monitor for your patient? Is their blood sugar, vision, underline the word vision. They're too big. Their vision is a problem. I want you to write down the word chewing problem. Is there pain in their joints, their vision problem, pain, and also their blood sugar. Everything is hyper. Remember, all their organ, write down the word organ-megaly. What is organ-megaly? All the organs are big. They're hyperfunction of the gland. That means their heart. Everything is bad. Simple question. Everyone, if you understand the word, you can answer your question. If they're saying your patient has acromegaly, what do you prevent them? Vision problem, fall. Chewing problem, food. Pain, ambulation. How do you treat patient with hyperpituitarism and acromegaly? I want you guys tell me, how do you treat acromegaly? They're already too big people and they have hyperpituitarism. How do we treat them? What is the treatment would be? Whenever you are hyper, you are removing the gland. So what is the word is called? Hypophysectomy. Everyone remember the word? I want you to write down hypophysectomy. I'm covering adrenal gland as I'm moving. Are we clear? Hypophysectomy. What is the second thing? See, if you only read one line, you're not prepared for the Nclex. You've got to know more. What is another thing you will do? Radiation. Are we clear? Radiation, you are destroying the gland. What is hypophysectomy means? You are removing pituitary gland. What are the two surgery everyone should know? You are removing pituitary gland. Where is your pituitary gland? It's in the brain. How do you remove? Remember the word craniotomy. So write down the word craniotomy. So if they give you craniotomy, you remember they're going in the brain. It's a neuro question. What is another question is transphenoid. What is transphenoid word is in the nose. Are we okay? So how do we remove pituitary gland? Either you have to go through and drill and remove the gland, or what do? You're going through the nose and you're removing the pituitary gland. Where is your pituitary gland? In the brain. What is your pituitary gland is producing? Growth hormone. What is another hormone from your pituitary gland? What is another hormone? I want you to write down two hormones, growth and ADH. Are we clear? What is another hormone? ADH. And what is ADH does? What is ADH affect? In the water urine output. What do you do when your patient come back after craniotomy and transphenoid hypophysectomy? Number one, anything coming from nose and here, what fluid are you losing? Cerebral spinal fluid. Are you going to monitor level of consciousness? Yes. How do you know cerebral spinal fluid? Positive for sugar. Number three, urine. Your questions are nothing with level of consciousness. Why do you monitor urine output? Because they're going to be showing symptom of diabetes insipidus. Are we clear? What do? They will pee more. And what is that word is called? Polyuria and polydipsia. Your patient wants water. Do you give them water? Yes. See how you got to connect. Everyone is okay. What is acromegaly is? Hyperpituitarism. What are you removing from pituitary gland is you monitor is since it's in the brain your ADH. Are we clear? Your question has nothing to do in exam and they say your patient has hypophysectomy and patient want to drink water. What are you going to tell CNA? It's okay. Give water. Why? Because they are peeing more. They're not absorbing back the fluid. Are we clear? See how you got to connect. I want everyone remember the word acromegaly is what? Hyperpituitarism. What is your pituitary gland is producing? Your growth hormone and ADH. And what will be the problem when you remove pituitary gland or head injury question? They're going to pee more. And that's called diabetes insipidus. So what did we cover here? Endocrine system and pituitary gland. Bone marrow. Bone marrow, they can aspirate from the bone, but the best site is called iliac crest, underline, and it's very painful. And what do you prevent patients? So remember, bone biopsy or bone marrow, you give them is what? Pain medication. It's very painful. And what is second thing you monitor? Infection. So a sterile technique, make sure you prevent from infection. Since we talked about acromegaly, and I'm going to ask you to remember the word is growth hormone, we said, and now I'm going to talk about craniotomy and post-op care, supratentorial and infratentorial. So let's write it down, craniotomy. So if they give you a question, craniotomy, and supratentorial and infra, they all are going in the brain. Supratentorial, infratentorial is craniotomy. Are we clear? So they ask you what position. Now in your notes, supratentorial, you guys have elevate the head 30 to 45 means semi-Fowler's position. As soon as your patient comes, don't put them in bed, but raise the head. What position? Semi-Fowler's. Infratentorial, keep them flat. Craniotomy, keep them flat. If ICP goes up, any question, then you go semi-Fowler's position. Are we clear? And we already talked about what do you monitor craniotomy patients are, is diabetes insipidus, fluid. Any question come level of consciousness, it's ICP. And also remember, craniotomy can lead to meningitis because it's a surgery. An infection, 3 things with craniotomy, monitor ICP for your patient. Number 2, monitor diabetes insipidus. And number 3, meningitis. I want you to write down like that in the questions. Are we clear? So if they give you on these question, craniotomy, you are monitoring your patient on these part on your question. And I would connect that with your craniotomy, transphenoid, and all these part of your endocrine system. So everyone is okay. We talked about what gland? Pituitary gland. Where do you have craniotomy? Neuro. Are we clear? What are you removing through craniotomy? Maybe pituitary gland, or maybe you have a tumor in the brain and patient has bleeding in the brain. So what are they going to do? They're going to go through the craniotomy. So what is your position? Only remember supratentorial, you keep the head up. Everyone remember what is the complications of craniotomy? ICP. What do you monitor in ICP? What do we monitor in ICP? ICP, what do you monitor? You are a nurse. What are you going to monitor in ICP? Number 1, level of consciousness. Number 1. Number 2, I want you to write down vital sign. And number 3 is pupil reaction. We are nurses. You got to show what do you monitor. Don't use the word I monitor. And I monitor ICP. Well, what did you monitor? Is a neurological assessment. Level of consciousness. What is vital sign of ICP? Your blood pressure goes up, your pulse goes down, your respiration goes down. What is pupil reaction? If your pupil are dilated and they are fixed, that means your ICP is there. Are we clear? Dilated. It should become constriction. It didn't constrict. So everyone is okay. Acromegaly is what gland? Pituitary gland. Craniotomy, we talked about position. Only in supratentorial you elevate. Infratentorial, you keep them flat. Orange juice is acidifying the urine. Write down the word, not alkaline. Acid ash diet is a acidity. It makes it, does not help acidify, but is more alkaline. So where do you know acid and alkaline ash diet? In urinary system. So orange juice is good for alkaline. Cranberry juice is good for acidity. Are we clear? Next is myelogram. Myelogram is the procedure you're looking for the muscle in neuro. And if they say patient is going myelogram, you do need consent. Gram means you need to check allergies with iodine. But after the procedure, very important, if you have water-soluble diet, they used it, dye, then elevate. If oil-based, then keep them flat. Are we clear? So all your procedure, iodine question is important. You check for allergies. Now I will move on fractures. What is in the fractures are, what do you do when your patient has fracture? What do you do when your patient has fracture? Is immobilize. And why do you immobilize? To prevent what? Fat embolism. I want you to write down the word fat embolism. What is fat embolism leading into? Pulmonary embolism. Second thing, cover the wound and clean. Write down the word wash with soap and water. Wash with soap and water and cleaning. What are you preventing? Osteomyelitis. Write down the word. What are you preventing? Osteomyelitis. Number 3, check color and capillary refill at the distal part. Write down the word is you're checking pulse and write down neurovascular and why to prevent compartment syndrome. Are we clear? Then how do you treat if there, so 3 problems, pulmonary embolism, osteomyelitis, and we already said compartment syndrome. What is a compartment syndrome? Poor circulation, poor nerve problem. What do you do for your patient if they have compartment syndrome? I want you to write down the treatment for compartment syndrome are, number 1 is, what do? Is you are going to open it, and second one you have is bivalving. Bivalving, you cut the cast. So write down bivalving. And second treatment is fasciotomy. What is fasciotomy? You're going deep and you're doing surgery and you're removing the dead tissues. Are we clear? So what are the 2 treatments they do for compartment syndrome? Now your question is, your patient has compartment syndrome, that means they're poor circulation. So what do you do when your patient starts compartment syndrome? Either you cut the cast, make it loose, or if patient has compartment syndrome, you do surgery and remove the dead tissue. And why do you do it? I want you to write down to improve circulation. What is it improving? Circulation. Are we clear? To improve circulation. Otherwise, patient would have problem. Close reduction means manually. What is manually? Fixing the bone by hand. When we are saying open reduction, I want you guys write down close reduction. Open reduction means the surgery. And they have opened it and they have fixed the bone. They have done the surgery. That is called open reduction. So everyone know how do you take care of your patient with fractures, immobilizing, prevent osteomyelitis, check the temperature, that's called circulation, close reduction, and open. What is open reduction? Surgery. Are we clear? And they call ORIF. Now, if they have a question with traction, what is a buck's traction? It's a skin traction. Why do you apply traction? Underline the word. To relieve the muscle spasm. What are you relieving in traction? The muscle spasm. And also write down immobilize. Why do you apply traction? To immobilize. There are 2 purposes. So one is to relieve a spasm and immobilize. Number 2 is muscle spasm you are relieving. And number 3, if used for fracture, only can turn on unaffected side. So they can turn on an affected side. Weight 8 to 20 pounds of weight. If used for scoliosis, will use 40 pounds. So if they're using this traction for scoliosis, more weight. Elevate the head of the bed. Very important line in a buck's traction. Either they elevate the head of the bed or foot of the bed for counter traction. Highlight that word. Last line, use the pillow under the leg and on to immobilize and to place the pillow below leg, not under the knee. Never use pillow under the knee in fracture. So what is a buck's traction? A skin traction. Are we clear? What do? Elevate the head or foot of the bed to apply counter traction. What do you monitor for buck's traction? Write down skin assessment. Prevent skin breakdown. Skin breakdown. Write down there, skin breakdown. Next is Russell traction. What is a Russell traction? Is also a skin traction, but they use sling. That is very important in skin traction, the Russell traction, because there is a sling used where? Right down under the knee. So what do you monitor here? Below the leg and the heel of the bed and popliteal space. What is a popliteal space? Under the knee for circulation. And also lift the patient, not the leg. Do not turn the patient from the waist side. Now mostly your traction patients are use trapeze and let them lift up. Are we clear? So that's it. So everyone should know Buck's traction is a skin traction, Russell traction, popliteal space. Next page is on cervical traction. It can be your cervical traction for neck and no pillow, cervical traction for the neck. Suspended suspension traction, write down with Thomas Plint. If they're using the word with Thomas Plint, they are a skeletal traction. It says there is a skin traction. This is called skeletal traction. And with suspension traction with Thomas for femur and maintain continuous pull. Halo jacket, also used halo for spinal cord injury. It's also a skeletal traction. So write down, if your patient has spinal cord injury, they're using halo traction. And what do they have? This is a skeletal traction. What do you monitor in skeletal traction? Your answer would be pin cleaning. And write down the word sterile technique, sterile gloves. Not only cleaning, but make sure you prevent them from infection. Now, if I go on, and also I want you to write down another skeletal traction, 90-90. They can use in adult and children 90-90, and that's also skeletal traction. Another skeletal traction is called crutch field. They use on the head, and it's called crutch field, C-R-U-T-C-H-F-I-E-L-D, crutch field. And when they use the word tongue, crutch field tongue, they're using in the skull. Are we clear? And that's a skeletal traction. Whenever they're using the word pin is used, that's a skeletal traction. When they use halo traction, skeletal traction. 90-90 is also your skeletal traction. Are we clear? So what do you monitor in traction patients are? I want you guys write down a little bit. How do you know your traction is in place? Number one, write down the weights are hanging freely. You're using the weights and they're hanging freely, mean they're not touching bed. Number two, ropes. Ropes is on pulley. So what the rope is on the pulley. Are we clear? So the rope is going over the pulley and the weights are hanging freely. That means your patient is not touching foot, this is not touching bed. Are we clear? The weights are not touching the bed. Ropes is going over the pulley. What are the things you are monitoring in traction questions are? Your patient is risk for in skin traction, is skin, a skeletal traction, infection. Are we clear? What are the other problem in traction patients are? Constipation and UTI are there. So because they're laying in a bed, they can develop UTI. So maybe your question, patient who's laying in a bed and they are having a traction, what do you monitor for UTI, and what do you monitor here is for constipation. So give them fluid and prevent them from UTI. Are we clear? Now the next is cast. Any question come with cast. What do you monitor patient with cast are? Is leg is shortened. Which leg? In which fracture? Hip fracture. Write down in hip fracture, the leg is shortened. And adduction, they're going in the middle. You want to keep them away. Number three is rotated, very important. Now I want you to write down another sign and symptom, disalignment. Disalignment. So if they give you a question, patient fell, what are the signs of hip fracture? The leg is shorter. Adduction word is important. Rotation word is important. And disalignment, and write down the word crepitation. Crepitation means the rubbing of the voice in the bone. Crepitation. So these are important sign and symptom of fracture. So what are the sign and symptom of fractures are there is the shortening of the leg, adduction, and extremity rotation, and disalignment and crepitation. What do you do when your patient has fracture? Is always, we already said, immobilize your patient. Be clear, osteomyelitis you prevent. But if your patient come back after hip replacement, what do you do? After hip replacement, questions is number one, abduction pillow. What are you using? Abduction pillow. Crutch walking, non-weight bearing, 3-point gait. Write down non-weight bearing. What is non-weight bearing? 3-point. And also remember the word do not flex. Don't raise the head of the bed. Do not flex leg 45 to 60 degree. Write down the word do not raise the head too high. And also no regular chair, because what will happen, they will go more flexion. Are we clear? You can go recliner. Do not elevate. So how much they can flex the leg? No more than 45 to 60 degree. I want you to write down is trochanter roll. Trochanter roll is important for preventing rotation. All right, so what are we preventing here? Rotation. How? By using trochanter roll. Everyone should know, what side do you turn your patient with hip surgery? Unaffected side. Everyone is okay? Do not raise the head of the bed. Do not put them in this chair. And what kind of toilet are you going to give them? High toilet seat. Why? To prevent flexion. Are you going to ambulate your patient? No. What are you going to do for ambulation? 3-point gait. That's a non-weight bearing is on that leg, and you're using 3-point. Are we clear? What is 3-point? You move the crutches and you move the affected leg with the crutches. That is a 3-point. So I think we'll take a break now for 10 minutes, then we'll continue.